So thank you all for coming. And just to get a little poll, how many people have heard of Shepherd Pratt before? Okay. So we are located just north of Baltimore, and there's our center, which is the Center for Eating Disorders, and we offer 4 different levels of care. So we do outpatient, intensive outpatient, partial hospital program, and inpatient. So just to kind of put me into context in terms of where I'm coming from. So what we're going to spend the next couple of hours talking about, and looks like we're going to shut down here if I don't postpone this. What we're going to be talking about today is a pretty new movement within the field of eating disorders, which is really seeking to be more inclusive of the friends and family members of the person who's been diagnosed into the actual treatment. And this offers sort of a creative way to do so when maybe the person isn't actually willing to have their friends and family involved in their treatment, or there's, for whatever reason, some limitations in how available the family is to participate in that person's treatment, maybe because of geography or age or just different variables. And so it's something that really makes a lot of sense to me. When I was in graduate school in the 90s, we really weren't doing a ton with family members in terms of eating disorder treatment. From what I remember is we would sort of recommend family therapy when it was really obviously needed. And I would march out into the waiting room and get an adolescent, bring them back, do individual therapy, send them back to their family, and kind of send them on their way. And we're doing things incredibly differently now in terms of, especially for adolescents, making the family therapy really the primary form of treatment in a lot of cases, and just making sure we're doing a lot more interacting with the families. And our own program has really sort of revamped over the last couple of years to really put more emphasis on the family's involvement in the treatment process for all age groups, especially for the adolescents, but really through adults as well. So the collaborative caring model was something that was developed by Janet Treasure, and she's a psychiatrist in the UK who works with the Maudsley Hospital. So a lot of the information that we'll be talking about today is stuff that I have learned from her presentations and her books, and then I'll talk with you about how we've sort of modified it to fit with our needs in our program. But I really want to emphasize that I recognize that not everyone in the room is working with an eating disorder population most of the time or even some of the time. But I would like just to kind of point out that a lot of what we're talking about really can also be modified to be appropriate for friends and family members of people who have other diagnoses. So people who maybe have, pretty significant depression or substance abuse, or personality disorders, really anything that the friends and family members may need more support in being supportive to that person. So that's just something to kind of keep in mind as we go throughout the presentation. So I know, just keeping in mind that the Farley Center does a lot of work with substance abuse, I thought I would just touch a little bit on how eating disorders and substance abuse can kind of go together. And some of these statistics, when I first came across them, I thought, that seems kind of high. But then as I stopped and really thought about my caseload, I started to think that actually it made a lot of sense. And so a lot of the research indicates that as many as 50% of people who present with an eating disorder also can be diagnosed with a substance abuse disorder. And then of the people who are in treatment for a substance abuse problem, 35% may be in treatment for or may present with eating problems. So that's a pretty high crossover between people who have substance abuse problems and eating problems. And then keeping in mind that people who binge and purge are more likely to present with substance abuse problems than the people who are just true restrictors. And that's partially based on personality factors. People who are restrictors tend to be a little bit more constrained generally in their behavior. So in terms of thinking about the substance abuse in the context of the eating disorders, substance abuse problems can be used as a way to facilitate the eating disorder. So thinking of diet pills or any substance that's going to perhaps suppress appetite or increase metabolism, or thinking about sometimes males more typically are using steroids as a way to kind of create an aesthetic of a lot of muscles or a certain look. So sometimes these substances can be used as a way to help the eating disorder along, and then in some ways the substances can also contribute to exacerbating eating disorder problems. So there's a term in popular culture, I'm not sure if you've heard of it, drunkorexia. Has anybody heard of that? So this is something that refers to, taking an individual who may have alcoholism, who chooses to consume their calories by alcohol and then not eating food because they don't want to take in so many calories that they think they're going to gain weight. And so I have definitely had people on my caseload who will do this, where they'll go, a couple of days without eating any food because they're trying to compensate for the number of calories they've taken in by alcohol. So that's definitely a big problem, and just an example of how somebody who's battling the eating disorder and the substance abuse together can really run into problems in terms of how to prioritize what to work on first, and being really cognizant of the possibility of symptom substitution. So that's just a little sort of foray into the eating disorders and substance abuse overlap. But what we're really going to talk most about today is, again, the collaborative care. And my experience has been that sometimes other providers will, when they find out what I do and what I specialize in, and actually I'm thinking specifically of my own physician, almost every time I see my physician comments on, like, I don't know how you do your job, like that seems like the hardest population to work with. And I think that there is a stigma about eating disorders where people think of that population as particularly difficult. And in some cases that's true, but it's also very rewarding. But I always think about that I have, at most, because I work outpatient, I have like 1, maybe 2 hours a week that I spend with each person, and then they leave my office and they go home. The people that's not the case for are the parents, the significant others, the spouses, the friends, the people who are really present in that person's life. They are with them all the time at the most stressful points, and so they're really not experiencing a break from the severity of the disorder itself. And my experience has been that when I've been at health fairs, that it's the friends and family who often will come to the table because they're desperate for information, they're desperate for support, and they really want guidance. And sometimes they're more likely to seek that out than the person with an eating disorder. And so what I really like about this particular model is that it really offers some specific skills and information for them that will help them to feel empowered, and that will help them to feel like they have some kind of support in going through this process. So historically, we have not always been that kind to the friends and family of the people who have an eating disorder. And so I thought we would just take a little brief tour through history to look at some of the quotes that are in the literature about friends and family. This is 1860. I do not know how to pronounce this person's name. Marseille, I'm not sure, but we'll go with this doctor. In 1860 said, in regards to anorexia nervosa, this hypochondriacal delirium then cannot be advantageously encountered so long as the subjects remain in the midst of their own family and their habitual circle. It is therefore indispensable to entrust the patients to the care of strangers. So what we see here is in the 1860s, the idea really is that the friends and family are going to be, a negative impact on the patient, and so the patient really should be pulled away from them, and access to them should be pretty limited because it's thought that they're going to make things much worse. In 1873, this doctor said the patients should be fed at regular intervals and surrounded by persons who would have moral control over them, relations and friends being generally the worst attendants. So again, we see that the friends and family are not thought of very positively. 1936, Dr. Riles says the first essential after diagnosis is to explain to the patient and the parents separately the nature of the disease in the simplest and most direct terms. And this keeps wanting to shut down, so bear with me. And then visitors, and particularly near relatives who are likely to cause tears or other emotional reactions, should be disallowed or strictly rationed at first. So we're making a little bit of progress where the friends and family are included in getting some information, even though it's separate from the patient. And if they're not causing too much problems, they're able to visit with the loved one. But again, it's sort of a skeptical view of the family members and sort of seen as they're probably going to be a negative influence on the patient, so we need to be very careful with them. In 1962, Hilda Bruch, who wrote The Golden Cage, which is a very classic book about eating disorder treatment, says self-starvation is symbolic of a struggle for control, autonomy, and self-respect. The struggle results from the mother not recognizing the child's expression of their independent needs, and therapy should focus on challenging erroneous assumptions and attitudes. So we're getting closer. We're getting more into sort of the modern day kind of approach, which would be to challenge those thoughts and assumptions. But again, there's still some negative impacts or influences on the mother, or from the mother. And now this is, oh, there we go. So in the 1980s to the 2000s, which is in the 90s was when I was in grad school, individual therapy using a CBT framework was really, the ideal way of conducting therapy with eating disorders. And for adults, that's still the case. So CBT is still the treatment of choice for adults with an eating disorder. Nutritional counseling, psychiatric follow-up, medical stabilization, and then family therapy really as needed. It wasn't the main source of treatment for anybody with an eating disorder, really. Whoops. Okay. So in the late 90s and trending towards today, how many people have heard of the Maudsley method? Okay, just a couple of people. So within the field of eating disorders, the Maudsley method, or family-based treatment, is really where most of the current research is pointing for sort of advancements within the field. And if you look at just the general rates of recovery with eating disorders, there really is a lot left to do. The rates aren't that great, and so there's sort of a sense that we don't really 100% know what works best. But research is showing that the Maudsley method is really getting closer to having more successful recovery rates for adolescents. And the method is something that was developed in the UK at the Maudsley Hospital, but really was brought over here by Chris Dare, Jim Locke, Daniel LaGrange, and Stuart Agris. And they have done a lot of work and doing a lot of research on testing this model. And the difference in this type of family therapy compared to other forms of family therapy is that the parents are put in charge of the refeeding process. So it's sort of like making an inpatient type of a setting at home. So what you're really working on there is that for an adolescent who has anorexia, the parents are going to be setting the same parameters. They're going to be enforcing, consequences if the person's not eating their meals. They're going to be helping that person to eat what seems like an appropriate amount for weight gain. And the therapist is working with the parents to really strengthen the parents' ability to do this. And we'll talk a little bit more in detail about this in a minute. But just to kind of really emphasize here that the parents are seen as a resource. The therapist takes an agnostic stance. There's no blame put on the parents. We don't know what caused an eating disorder. And the family therapy really becomes the central form of treatment for the adolescent with the anorexia. The adolescent usually is not in individual therapy until their weight is regained. And the reason for that is really that for anyone with really severe anorexia, they're not able to do individual therapy until their weight is close to restored, because their brain's just not going to be able to process insights and all those kinds of things if it's starving. So the number one goal of treatment for somebody who is malnourished is to get them nourished again so that their brain can actually process it. Yes?
And it's fascinating that, again, I was trained 25 years ago, where we always looked at that the cause of anorexia, it was a family system breakdown. So the parents were, it was a symbol of dysfunction. Statistically, I thought that was supported by research, and now you're saying that it's not.
So the interesting thing is about what your point is there is, you know, when I first, I'll give a little disclosure in that there was a nationwide study where they were looking at the benefits of this particular type of family therapy compared to just family therapy. And my site ended up being in that study, and I got assigned to the family-based treatment model. And I kind of went into it not really sure how I felt it was going to work. But my experience has been that a side effect of focusing on the parental involvement in the refeeding is that you end up doing all that other stuff anyway. You help sort of restructuring the family hierarchy. You get, you know, all the sort of underlying dynamics. The therapist is seeing that and sort of working to address those types of things. The research shows that really the only families who are going to have problems doing this are families who have a hard time setting any kind of limit. So it doesn't matter if it's a blended family. It doesn't matter if it's you know, a single parent family. The only thing that really is a negative indicator is the family who's unable to set a limit. And I had an example of that where I had an adolescent who really was wanting to do this type of therapy, but her parents were really unable to even enforce a curfew for her. And so they really couldn't enforce this kind of work. So I don't know if that really answers your question, but I mean, the research is showing that the family involvement, regardless of what kind of family dynamics there are, except for the parents who can't set limits, are going to be fairly successful at this. Yes?
So many times, especially with daughters, they were modeling the mother's behavior, so how are you going to address that?
Well, that comes up when we talk about, so in this model, which I'm going to talk a little bit more about, and then this is a whole other talk I could do for hours on end, and I want to make sure that we get to the collaborative care part. There's a family meal. So the second session, the therapist watches the family eat a meal together, and the family brings in what they think is an appropriate meal. And throughout those types of interactions and throughout the sort of reporting back in terms of how things have gone, it becomes very clear if there are parental beliefs about food that are unhealthy, or you know, sometimes the meals I find fascinating when they bring something and it's nowhere near enough food for what a person needs to be eating, let alone needs to be eating to gain weight. So you really get a sense of sort of the family's style and the family's belief set and what their behaviors are like through these types of interactions, and then the therapist is guiding that and correcting that as they go. So let me just continue on with this. In this type of therapy, hospitalization is really only used to stabilize someone if they're medically impaired, and the hospitalization is meant to be brief. And then, again, this is now the empirically validated treatment of choice for adolescents with anorexia nervosa. Yes?
Kind of taking off what the other woman was saying, if you have to do some work with the parents, is that done while the individual is still in hospitalization, or how? I guess I'm trying to figure out how, because some parents aren't ready to take that role right away, and you still have to get the kid stabilized.
Right. What we have done, and I'm thinking of one family in particular that I had where they were really laissez-faire. They had a really hard time sort of stepping out of that role. We worked with them about the need to set really specific limits, and in my first session with them, I'm like, this is going to be really different from anything else you've done before. You have to be able to set a limit for this to work. You know, we do a lot of work around that. And so we're working on that simultaneously, and then my experience has been that most families are able to rise to the occasion because there's such a sense of urgency about the welfare of their child, and as long as the team is really supporting them and moving to get there, they're able to work a little quicker because of that sense of urgency. Hold on. Okay. Let me do it this way. Okay, so again, we'll go through this sort of quickly because I want to get to the meat of the presentation, which is really the collaborative care workshops. But the fundamentals of the FBT approach is that the first phase of treatment is the parents are set to refeed the patient. The therapist is working very closely with them to get a history of how the anorexia has affected the family. We're getting information about family functioning. We do the family meal. And we really, again, are helping parents take charge and using the siblings for support. The second phase, and this generally lasts on average over 9 months. And it's very cost effective because it's really, about 20 sessions or so over the 9-month period. And for most families, I would say this has been sufficient. And again, this is for the refeeding process. So at the end of it, the adolescent may be referred for more individual therapy. During the second phase of treatment, usually after about 4 months, about 10 or so sessions, once you see some compliance with the eating, the control is very gradually handed back to the adolescent. So the adolescent practices managing their snacks on their own, or maybe their portions. So they get a little bit more control, a little bit of more practice, because we want them to be able to have that control, because there have been examples of some adolescents who have done the first phase of this model, and then their family sent them off to college, and now they're at college and have no idea how to eat. So that can be very problematic. So we want them to be able to guide these decisions independently, but we want them to learn to do so with a good safety net. So we return gradually those decisions and those control back to the adolescent, and we start exploring more of the adolescent developmental issues and how it relates to the eating disorder. And then in the third phase, which is really sort of the wrap-up of the type of therapy we're doing here, you review just normal adolescent issues with the family, establish that the parent and adolescent relationship really doesn't need the eating disorder to facilitate communication, and then termination. And again, this is very successful, empirically, for getting the weight to come on and to get the eating disorder symptoms to subside. Usually at the end of this, the adolescent would be referred for more individual therapy work to usually focus on the other stuff that's been going on, and also usually body image takes a little bit longer. But from this model, and I have to say, when I was put into this type of therapy and I had to go by the manual, it really changed how I do therapy in general, because I had been so focused on the individual work and helping the individual to make a lot of those decisions. And in particular, the work that I had been doing with my adolescents, I became much more inclusive of the family members and of the people in their lives and bringing them in and looking at them as more of an ally to the treatment process. And so Janet Treasure, who again is in the UK, developed a whole model called collaborative caring, which really seeks to open up this type of mentality, I guess you could say, in the field to all friends and family members who would be involved in the recovery process of someone with an eating disorder. So just to go over the lingo a little bit, in the UK they use carer. We usually say caregiver here, but the caregiver really refers to any support person who's in frequent contact with the person who's been diagnosed with an eating disorder. And the loved one is the person who has been diagnosed with the eating disorder. So typical caregiver experiences. So most of the people that I have encountered have talked about feeling very frustrated and a lot of anger. And the anger can be at the eating disorder, but over time it can also shift towards the person with the eating disorder because they're just sort of feeling so helpless and frustrated with the lack of progress or, you know, the just shift in mindset from time to time. There's a lot of shame, and because, you know, perhaps they're wanting to protect the confidentiality of their loved one, they may not be reaching out to others for support, so they may not be letting the extended family know that the person's struggling, or they may not be letting their friends know that there's a problem within the family. And so there's a real sense of isolation for the caregiver because there may not be sort of the fluidity of support that they might be receiving elsewhere and in other circumstances. I just did one of my workshops with my collaborative care people on Tuesday, and we noted that for whatever reason I hadn't put fear on here, and we were talking about really it should be on there, just that general sense of fear of not knowing what's going to happen, what the outcome's going to be, or their loved one's health. So the caregiver needs certain things. They need education, they need support, they need to connect with other caregivers, and they need skills training. And this is where the collaborative care model becomes much different from what we've been doing before, because by skills we mean actual skills that the treatment team is using, like motivational interviewing, you know, knowing the basics of CBT, knowing how to separate the person from the eating disorder. So we're trying to teach these people actual skills that they can use when we send them home, you know, send the person home to try to work on their recovery in this context. Help them with referrals. We help them find resources and give them good bibliotherapy recommendations. You know, there's a whole bunch of literature out there, but they're not all created equal, and so helping them to find the good materials. So what are the typical stressors that people will talk about? Meals. They are, you know, grocery shopping with their loved one. They are eating breakfast, lunch, or dinner with their loved one. They are encountering all the sorts of triggers out in the world with that person. And so there's a lot of stress about, you know, not knowing how that person's going to react. So many of the families or loved ones have really modified their own routine to accommodate the person and their eating disorder. So many families, you know, when I've talked with them, will talk about that they no longer eat certain types of food in the house because it has been too hard for the person with the eating disorder to have that in the house. And so there's a lot of sacrifice in terms of family structure and in sort of the meals that the family are eating because there's such a fear of making the eating disorder upset. There's, again, the stigma of an eating disorder, the cost of treatment. Many families have had to dip into their savings even when insurance covers most of it because the treatment costs are very high, and the average course of treatment for an eating disorder is 5 years. So during that 5 years, ideally you have someone who maybe if they need a hospitalization only goes in one time, but unfortunately often it requires several hospitalizations, or maybe the person's doing well for a while and then they need a more intensive outpatient experience. So it's very costly. And the other cost is, especially for parents of an adolescent, and I have adults too who their parents have to do this. There's people who are needing to take off of work to take the person to all their different appointments and doing family therapy, and there's a big need for the family and the loved ones to be involved, and so they're having to sacrifice their own time and their responsibilities in order to do that. And so that leads to them having unmet needs. It puts a strain on their relationship with their loved one. And again, there's sort of a persistent fear of causing or worsening the eating disorder. The main obstacles that people will bring up is getting the person into treatment. And this is across the board for age, just kind of the process of what do you do when the person's not really wanting to go into treatment. A lack of resources, and this could be because of geography. We actually have a lot of people who come to see us outpatient, so they drive from like West Virginia and Pennsylvania. So there's not a whole lot of eating disorder treatment centers, at least in our area, and so people are having to drive pretty far to get to us because sometimes there's not even sort of a person in private practice who's interested in working with eating disorders available to accommodate that person. And especially when we start getting into them needing dietitians, that can be very difficult for people who are unable to access the appropriate care. Insurance is a problem. Some people's insurance will only give them X amount of sessions, or maybe they don't have insurance. And just in terms of family support. And then again, the confidentiality limits. And that's a really big concern for anybody whose loved one is over 18, and they really feel out of the loop in terms of how that person's doing or what their treatment team is recommending or having any kind of information exchange. And they, as a family or as a caregiver, feel really at a loss for what to do with that lack of information. So in the UK, there are a set of guidelines from the National Institute for Health and Clinical Excellence. I don't know if they say it this way, but to me it looks like NICE, so I'm going to call them the NICE guidelines. And they use literature reviews to determine best practices for mental health problems and medical disorders. And a grade A recommendation is the most reliable recommendation that can be made based on the synthesis of all the studies. The NICE guidelines for anorexia, there are no grade A recommendations because there are so many limitations on the studies for anorexia. It's very difficult because there is a diversity of cases, and some of the treatments that are used for anorexia are not specifically tailored to anorexia. They're just used for anorexia. So it's very complicated. It's very hard to really tease out what works. But the grade B recommendation is that family interventions should be offered to children and adolescents with anorexia nervosa. And then for bulimia nervosa, we have the grade A recommendation being that CBT should be used, focused on the eating disorder, and that family should be involved with adolescents. And then this is something that's very interesting that they've done. They made guidelines specifically for the caregiver. And so in the UK, caregivers are entitled to an annual assessment of their own needs. They're entitled to access information about the health of the person that they're caring for. And families should try to be incorporated into the treatment process whenever possible. So if you're like me, the first time I saw that, my big question was, how? How do you do that? And so it's not as difficult as it sounds, because ideally what would be happening is that there's going to be early dialogue in the treatment process where you're really talking about, to the loved one that you want to have someone involved in the treatment process and encouraging them to think of a person that they might be able to allow you to talk with. But then remembering that some of this information does not require patient consent. So the therapist can always provide general information about a diagnosis. So if the person's asking specific questions, you may not be able to give them specific information about that person. You may not even be able to totally acknowledge that you see that person for therapy, but you can give them general information about an eating disorder. You can provide them with an assessment of their needs. And what Janet Treasure has really sort of formed, and what we're doing now at Shepherd, is providing the caregiver with access to caregiver workshops. So what we do is we have an inpatient series of workshops and an outpatient series of workshops. I lead the outpatient workshops where there's 6 different modules, and so they come in on a weekly basis for 6 weeks, and they get an hour and a half of information during each of those weeks that are geared towards giving them more information and more skills for how to work with the eating disorder. And I'll point this out again when I get to that slide, but it's also important to kind of think about, we have a lot of people that we can do these workshops with, but you can also do this individually. So if you have somebody that you're working with who's very concerned about someone that's in their family or who has an eating disorder, you can also just do this type of work on an individual basis and giving them those skills and giving them some specific information. And then just keeping in mind that some information does not need consent. So, obviously if there's a high risk of harm to self or others, if the patient does not have the capacity to choose a level of care, if the involvement of the family is the least restrictive option, and there's evidence that family communication is good when the person's not ill, and there's no history of independent living. Now, on its own, none of those are just really, except for the first one, sort of carte blanche, like it's okay to just, disclose everything. But these are different things that can be considered when deciding when it is appropriate to violate the confidentiality limits for the health of that person. So the collaborative care workshop. What we're doing here is providing an opportunity for people to come, and it can be, usually for us, it's the parents of somebody who has been in treatment at our center, but it also is a place where people can come. We do get phone calls sometimes about, I have someone that I'm very concerned about, can you help me get them into treatment? And we offer them support in talking about how to encourage someone to come to treatment, but if they really have no luck with that, we can at least offer them these workshops. So this is a way for people to access something even if their person's not ready to access treatment in any way. Janet Treasure has said that she has done these workshops in all kinds of different forms. She's done them as all day long workshops. She's done them as a weekly workshop. She's done them in short bursts of time versus other longer periods of time. What we've decided on is for our outpatient, we do a 90-minute session that's over the course of 6 weeks, and it's ongoing, so the person can really jump in during any week. And these are really more didactic than therapeutic, so my role feels very different when I'm leading these workshops because it's almost like teacher role, where I have PowerPoints on some of these, and we go through and we talk about the information. And so it has a little bit of a different vibe than it would if it was more of a therapeutic model. And it really can be led by anyone who has familiarity with eating disorders. And on our inpatient unit, for example, we have a nurse who does the Saturday workshops for parents and family for the people who are inpatient or in a higher level of care. So just to point out the difference with the collaborative care in comparison to, a support group or something like Al-Anon, while those groups really do allow for the connection with other supporters, those also don't need the patient's consent. The collaborative care really, again, emphasizes learning the specific skills and strategies to use on their own. And I always say to them, I'm so guilty of, over the course of my career, saying in sort of our wrap up with my individual clients, I'll say like, okay, and if you feel really triggered, why don't you go just talk with someone, or, you know, let somebody know, and, you know, maybe that can help sort of delay the behavior. But I never really took into account that those people may have no idea what to do in that moment when somebody comes to them and says, I feel like purging. You know, that person may completely panic and not be helpful at all. And so this really is helpful for those kinds of moments and giving the family the specific skills of what to do in those types of moments, what to say, and we do a lot of role plays in these. So that's just sort of to clarify the difference there. So what should be covered? There's a book in the bibliography that is written by Janet Treasure that kind of goes through sort of all the research behind this and the different ways they've structured it. And then she has a book that's specifically written for the caregivers. And both of those are great tools. When we were sort of developing this, we were trying to think about what made the most sense based on what our program offered, so that there would be some consistency in what, you know, our clients were learning and what skills they were developing with what we were teaching the caregivers. And so what made sense to us, and again, this could be modified to fit sort of what work you're doing or what you think would be most helpful, is we broke it down into the first week going over just basic eating disorder information. Week 2, doing caregiver self-care. Week 3 is communication and caregiver styles. Week 4, we go over the stages of change and motivational interviewing. And week 5, we do emotional regulation, so like very brief introduction to DBT kinds of things and mindfulness. And then week 6, we go over CBT basics, basically. And I'm going to go through these weeks with you to give you a sense of what that looks like and to give you more information about that. So we'll start with the first week, but before I get into that, is there any question about anything so far? Okay. So the first topic that we'll go over is eating disorder basics. And what I'll do here is we review the diagnoses, and I'm actually going to go over these with you a little bit because there have been pretty big changes with the DSM-5. We go over eating disorders being egocentric and what that means. Eating disorders resulting in serious medical consequences, so I really like to emphasize that. And that early intervention really is crucial. So research shows that you have a magic 3-year window. If you intervene within the first 3 years of the onset of the eating disorder, you have a much better chance of a full recovery than if you wait much more beyond that. Again, we want them to know that it takes a while. There's an average course of treatment that's 5 years in length, and that a multidisciplinary approach really is the best. And that's because when they come to see us, we have dietitian, an individual therapist, sometimes a group therapist, a psychiatrist. And so that's a lot of appointments and a lot of driving around. And so sometimes the tendency is for people to start sort of dropping out of different things. And we really want the support people to understand it really works better if they're really truly involved in all the different aspects of the services that we have to offer. So I'm going to go through week 1 in more detail than the other weeks because this is probably the harder part of, if you're not working with eating disorders all the time, this is probably the stuff you're not as on top of. So we'll just do that so you have that information, and then the other weeks will be a little less in depth. But with the spectrum of eating disorders, I talk with them about that. At the very top, we have the diagnosable disorders, but then there's something that's called disordered eating in the middle. And I like to point this out because a lot of times there are other people in the family who fall into this category, and they need to be a little bit aware of that. And the disordered eating really refers to people who have an unhealthy relationship with food. So they may be dieters, they may be very focused on appearance, or if they eat something, they may feel like they need to go to the gym and burn it off. And then we also have people who I think of like Oprah, where they're sort of emotional eaters and are using food as a way to cope. And I only point out Oprah because she's been so open about that, so not to pick on her. And then there's the normative discontent, which is in our culture. Unfortunately, there is a norm of being dissatisfied with at least some part of your body. But most of the people who are in that category are not necessarily doing anything to correct the way that they look. They're just maybe a little dissatisfied with something. So we talk about this, and I also emphasize to them to be careful not to plateau too early in treatment. Sometimes people will make a good bit of progress, and so they're maybe no longer in the diagnosable disorder category. But as a clinician, we would still feel like there was some disordered eating still happening. And so we would want to be pushing them still to continue in treatment and challenging themselves until they're really at a place where they're eating well and in a healthy manner. And sometimes the family is tired, and so they also pull back from pushing and supporting. And so sometimes we see people settle out a little too soon in that disordered eating category. So I like to let the families just know that and be aware of that for themselves. So I am going to go through the diagnoses, and then at the end of the diagnoses, we'll take our break. Does that work for everybody? Okay. How many people are familiar with the changes that were made in the DSM-5 about the eating disorder? Okay, so a few of you. So we will just sort of go through these fairly quickly. We won't do it too in-depth. But they've basically changed the wording, and they've taken, the main thing in anorexia is they took out the word refusal. It used to be that they refused to take in the energy needed, and now it is just written as a restriction because the word refusal felt a little too much like the person had control over that and that it was like a choice they were making. But with the anorexia here, it's the restriction of the energy intake, which is not enough for how much they need, and so it leads to a significantly low body weight for them. And that's another key difference because this is more of the controversial point. You could have someone who may be, naturally their BMI is quite high, and then they restrict, and so they're at a very low body weight for themselves, but technically their BMI would fall within a healthy range. They could, in fact, be diagnosed with anorexia nervosa under this new diagnostic criteria, which is something that's pretty controversial because we've been always thinking of this as somebody who's very underweight. There's still an intense fear of gaining weight, even if they are underweight, and there's a disturbance in the experience of weight or shape. And what's not on here anymore is amenorrhea. So they took the amenorrhea criterion completely out, and that's no longer a factor in diagnosing. There's still the two subtypes. So there's the restricting type where the person is purely restricting. They're not binging or purging in any manner. And then there's the binging and purging type where the person's regularly binging or purging, but not to the point where it's really leading to significant weight gain. I'm going to be honest, I don't like this new part here. So they specify in partial remission or in full remission, and then they've added these qualifiers for when it's mild, moderate, severe, or extreme. And I think that this is just a total setup myself because our population is very competitive and also very minimizing. And so if I had somebody I was trying to get into the hospital and their BMI was like 17, they're going to be like, but it's just a mild eating disorder, it's not really that big of a deal. Or they're going to sort of see this as a challenge and work to get their way down into the more severe category. So I don't really like that. We talked as a staff about we would never make that public to our caseload in terms of we would try very hard not to even write that down. And I am curious to see how this plays out as sort of people have a chance to react to the changes that have been made in the DSM. So that's just my little blurb on that. For bulimia, we have the recurrent episodes of the binge eating with the recurrent inappropriate compensatory behavior, and that can be, self-induced vomiting, but it could also be fasting. It could also just, involve exercise or laxatives. And they changed the criteria here where the binge eating and compensatory behaviors now have to happen once a week for 3 months. It used to be twice a week. So now it's down to once a week. The reason, again, that they are trying to change most of the criteria here is they're trying to get people out of the other category, because there was like 50% of people with eating disorders fell into the eating disorder not otherwise specified category. And so the thinking was like, we must not really have these accurately defined if people aren't meeting these criteria. So they're trying to expand to include more people into these categories and get them out of the other categories. So with bulimia, it's not happening in a case of anorexia, so they are exclusive. And again, they did some qualifiers here where we have in partial remission or in full remission, and then mild, moderate, severe, and extreme based on the number of purges that they have per week. Again, well, with the bulimia population, I'm not as concerned about the competitiveness, but I still probably wouldn't make it public about whether or not I felt like it was a mild, moderate, or severe case with them. Binge eating disorder is now an official eating disorder. For a long time, this was a proposed eating disorder, and I think we were all kind of acting like it was an official disorder, but now it truly is an official disorder. With binge eating, there are symptoms with the binges that are associated with 3 or more of the following, and that is eating more rapidly than normal, eating until uncomfortably full, eating when they're not hungry, and feeling disgusted with themselves. But with binge eating, there's no compensatory behavior of any kind. And so people who have binge eating disorder do tend to be overweight. And the criteria here matches the bulimia criteria, which is that it's happening at least 1 day a week for 3 months. And then again, they have the qualifiers here that are very similar to the bulimia qualifiers. And eating disorder not otherwise specified is no longer a diagnosis. And again, it used to be the most common eating disorder. There is still an option or two for if you really don't know. There's other specified feeding or eating disorder, and this would be symptoms are still causing significant distress. Maybe they don't still meet the full criteria for the other disorders, and the clinician would record the qualifier explaining the specific reason. So the example would be they have an other specified eating disorder, bulimia nervosa of low frequency. There's something called unspecified feeding or eating disorder, which I think will be used fairly rarely. This is when basically the clinician does not have enough information to really make an appropriate diagnosis. So I can't imagine that people are going to be using this very frequently. Janet Treasure we have like a professional symposium every year and a half, and she came to ours 2 times ago. And one of the things that she was really highlighting was that we need to do a little bit more education too about just the impacts of the eating disorder on the brain. Now, this in particular refers a little bit more to somebody who's been restrictive with their eating, but the key point here is that the human brain needs to have 500 calories a day alone just to function. And so if anybody's worked with some pretty severe anorexic patients, you'll be thinking about sometimes they're not eating much more than that. And so what we see is that starvation really does impair brain functioning and especially the cortical regulation. So, yes?
Is there no longer a weight requirement? I mean, it used to be there were a certain percentage of normal body
somebody whose weight is low based on their own sort of developmental history. So usually that's determined by, in our office it would be the dietitian or the physician who has their charts and their history.
And all that other stuff and times of life, when they're going through.
Well, that would all be taken into consideration. So our dietitian, for example, takes a lot of information about at different periods of time, how much somebody weighed, what was the longest time they maintained a certain amount of weight, what was their lowest point in time, what factors were happening during that period of time. And, it's a little easier when someone's a little younger because we usually have access to their growth charts and their information so we can see sort of where they may have fallen off and what, if they had continued, what their weight should be. So that's usually determined there. In theory, the DSM-5 makes it easier to kind of put people into those specific disorders instead of the ED-NOS, which was what most people were falling into. Okay. So in terms of how starvation impacts the brain, what you see there are problems with being able to learn new information. It makes people more ruminative, so their attention gets stuck. It makes it harder to regulate emotion. And they may have a harder time seeing the bigger picture. And so how that impacts treatment, there's difficulty in breaking habits. It's harder to see the bigger picture. It's hard to regulate those emotions. It's hard for really developing empathy. And, as you're going through this, these are sort of the main things that make it hard to work with somebody who's really struggling with their eating disorder. And it sort of creates this bad cycle where you can't really get them out of the problem that is creating this without them just starting to kind of improve their nutrition. And so this is where we really get into why recovery can be so difficult. And until nutrition improves, that brain function is really going to remain impaired. And sometimes it takes a little bit of time. So even when the person's functioning or their eating is restored, it may be a little bit longer time. Yeah.
Basically, you personally are basically focused with adolescents?
No.
Okay, so if you've got a person who is early 20s, has been restricted to 500 calories for a while, doesn't see a problem with it, family is not local, how do you approach that? Because, it's very difficult to get them to start refeeding without getting into, I'm gaining weight, what do I do, body image and all that stuff.
Right.
Do you use this model for that?
Well, so I would use this information to educate them. If somebody, and I would be sort of pushing them into trying to do a higher level of care if their intake is that low. But this model is really meant to provide information to the support people so that it can help mobilize them to kind of use that same information and be sort of a broken record like we are with them. So it kind of adds to that approach. So there is an interruption of brain maturation for people who have been struggling with an eating disorder during that maturation process. And caregivers need to be aware of this because they need to provide a little extra support. And again, it takes time after weight restoration for those maturational changes to restart. And I have a family right now that I've been working with where their son is 27, but he's had this eating disorder about 10 years. And so in a lot of ways, even though he has had a job and has had a relationship, it just doesn't seem to click on the same level that it would with other 27-year-olds. It seems sort of a little regressed. And I'll always say to them, well, it seems sort of like he's a little stuck in sort of the teenage, mentality. And the family will often say or a toddler. But really what we're seeing is that the maturation really kind of slowed down and has not really caught back up because his eating disorder has persisted. So this is what I call a blueprint for an eating disorder. I call it the trigger cycle. And this is something that I use in individual therapy with people, but I also use it with the families just to kind of help them understand what's happening here. So the top is the emotional trigger. So we'll use anxiety as an example. And so we look at the anxiety causes physical and cognitive symptoms. So examples of that would be, butterflies in the stomach, what I call pinball thinking, where it's like, what if this, and all the real racing thoughts, heart rate changes, all those good kinds of fun symptoms of anxiety. And because that's not comfortable, we all try to get rid of that feeling in some way. And so there's healthy ways of coping, and there's unhealthy ways of coping. And so, of course, the healthy ways of coping are things like journaling and yoga and meditation and relaxation and, for some people going on a walk. But then there's the unhealthy ways, and that can be for an eating disorder, binging, restricting, purging, exercise, and then, you can start getting into other things like compulsive spending, self-harm, substance abuse, promiscuity. So any of those kinds of things can be in that category as well. In theory, the symptoms decrease, you get to baseline, something happens, and the cycle continues. What's different with our unhealthy coping strategies is it sort of short circuits. So you have the anxiety or whatever emotion, you have the symptoms, and then you have the unhealthy reactions, which work really, really, really well in the short term. And that's what makes it so hard to stop, because in that immediate, moment, it may feel like they've even numbed the emotion, or it may feel like they're completely distracted from it. So in that moment, it's a very powerful way to not have to feel an uncomfortable emotion, but in the long term, it of course has negative consequences and can be an emotional trigger in and of itself, because then you have guilt or depression or anxiety or other emotions that are uncomfortable. And so we talk with the families about how the eating disorder really is, from our viewpoint, a coping strategy that has worked in some ways, but obviously has caused a lot of problems. But we kind of try to emphasize why it makes it so hard for them to really recover, and where we're sort of conceptualizing our interventions from, which would be, to help slow this process down, help them challenge their thoughts, help them to choose different behaviors and different coping strategies. So it's sort of a blueprint for thinking about it. We also talk about that there are the differences with eating disorders compared to other disorders, and one of these is that most people with an eating disorder tend to still be pretty high achieving. So they're doing well in school, they're getting great grades, they're excelling at work. Families with adults who are struggling, we'll talk about often they're like getting really great recognitions and promotions at their job, and nobody really has any idea how much they're struggling, because everything seems to be fine except their underlying medical condition. And so one of the things that we teach about is that eating disorders are egosyntonic. Does everybody remember egosyntonic versus ego-dystonic? Okay, this took me a long time to really nail down what it means. But the egosyntonic basically refers to that the person's behaviors are in line with their values. So if anybody has seen me speak before, they've heard me give this example of, has anybody read Dropping the Baby and Other Scary Thoughts? Okay, it's a book about postpartum anxiety. And I read it for a continuing ed thing when I was postpartum, which I don't recommend, because then it gives you intrusive thoughts about dropping the baby and other scary thoughts. But the idea here was that I thought this really gave a great example. So people who have most parents have intrusive thoughts about, like, what if something bad happens to the baby? What if I drop the baby? And the point of the book was saying that anxiety about those thoughts is actually a really great sign, because it means that it's ego-dystonic. So it means those thoughts are at odds with the person's values, so they're probably not really going to hurt the baby. On the other hand, for somebody who may be, for example, psychotic, they're going to have those thoughts and it may feel consistent with their values, so they may actually hurt the baby. So that lack of anxiety is actually a little scary as a clinician because they may not see that as being something that should be avoided. So the scary thing about eating disorders, and especially early in treatment, and particularly with the anorexia, is that the eating disorder does not feel at odds with the person's value system, and so it really leads to very low motivation or sense of urgency about seeking help, and that can be extremely frustrating as a treatment provider and also as a family member, because on the outside, obviously, there are really horrible consequences from this, but the person's really not experiencing it as problematic. So there's a very popular book that you probably are aware of called Life Without Ed. It's by Jenny Schaefer and Tom Rutledge. And then there's a follow-up couple of books. I think the next one is Goodbye Ed, Hello Me. I can't remember what the third one's called. But the basic principle of those books is externalizing the eating disorder. She refers to the eating disorder as ED. A lot of our population has adopted that, and so most of the people in our center have at some point come across this book and refer to their eating disorder as ED as well. And so what they're doing is they're looking at their eating disorder as separate from themselves and saying, like, well, those are Ed's thoughts versus my thoughts, or that's Ed showing up. And so we want to educate the family that I have had a mother come to me and say, I think my daughter has like multiple personality disorder now. She keeps talking about this Ed, and I'm like, no. It's okay. We taught her that. So just some ideas that we would use to try to help the family see that is thinking of it like a Venn diagram. So, this circle is Jimmy, and this circle's the anorexia. How much of the circles overlap? For people who are really severely struggling, they'll say that there's a complete overlap, so that there's no part of Jimmy that's exposed, versus somebody sort of more in the midst of treatment will have their circles partially overlapped. So we use that as a way of thinking about how present the eating disorder itself is. And we talk with, I'm always very open with the families that as a provider, we too get frustrated. And there are times where we are just almost angry and, really annoyed that this person's not doing what we've been talking about, or they're not implementing and they're not getting better. And so, one of the skills that we as clinicians do is we step back and we think about it and we conceptualize it a little differently. And in our case, it's always helpful to think about, okay, that frustration is really at the eating disorder and not at the person. And so that's helpful for the family to pull back and say, okay, I'm frustrated at Ed and not at Jimmy. And then we also sort of coach them on engaging in conflict with the eating disorder is also different from engaging in conflict with Jimmy. I have an example of a patient who for years had a boyfriend who, and they were in college, he would accommodate her eating disorder's desire to never eat past 5 o'clock. So they would go out to dinner at like 4:30, like early bird special with like these college kids and a lot of older adults, and he was really accommodating to that. And she was able to say, a while later, I needed him just to say no. Like, no, we're not doing that. We're going to dinner at a normal time, like normal people, and we're not doing that. But people are very hesitant to engage in that conflict, and so it's good to coach the families that it's okay to set the limits with the eating disorder, and if there's conflict, that's fine, because you're fighting the eating disorder. And I always talk about some of that pushback is actually good, because it means you're winning, and that's different than just engaging in conflict with them. And family members and friends, especially siblings, are really helpful in helping that person feel normal and do normal things outside of eating, and we really want them to continue to do that through the recovery process. So we'll also review during that first week just what treatment goals and expectations are. We'll review the empirically validated treatment options. We provide referrals and recommend books. I give them sort of a list of my favorite books that I like to recommend. We'll also talk briefly about different levels of care, inpatient, partial hospital, intensive outpatient, outpatient. We do not have a residential center, and I don't think there is a residential center in Maryland, so we usually have to refer out of state. Residential being usually for people who have tried inpatient a few times and they're just not making progress. So we'll just go over with the family a little bit about what warrants inpatient treatment. The bottom line really here, because we have other stuff to cover, but the bottom line here really is if somebody's labs come back negatively, where there's anything wrong with their labs, there's anything wrong with their vital signs, anything like that is an immediate recommendation for a higher level of care, and usually inpatient. So the inpatient is really seen as a way to stabilize a person medically. At our center, we usually try to keep inpatient stays to only 1 or 2 weeks, and then they would step down to a partial hospital program. So this is just, I put these pictures in mainly for the families because I know before I had ever set foot inside of an inpatient unit, I thought of them as like sterile hospital type settings. And so I give them pictures of like, but it looks pleasant, see? So this is like the dining area, this is where they would eat. This is like the nursing station. And so then the partial hospital program is where people would stay for a little longer, so usually 3 or 4 weeks on average. Some people stay longer. And this is our 12-hour program. So they still eat 3 meals with the inpatient people, but they go home overnight and have some practice in managing symptoms overnight. And then they would ideally step down into our IOP, which is a 4-hour program 4 days a week. And that's used either as a step down or for people who just need like a little bit more intensive treatment than outpatient. And this is where they would eat dinner, but they would not do breakfast and lunch. So this is great for people who are working and they can still engage in work or they can engage in school, but still get a little bit higher level of care. And then outpatient. And then we talk about, the residential is for people who are needing more than what we can offer. Yes?
And you mandate that someone has to go to the inpatient based on their danger to self because they're going to,
Yes.
how does that work?
So a danger to self is an interesting question because I will say a lot of our inpatient admissions do come from people who are suicidal and have an eating disorder. But if there is, so if there's a danger to, the danger to self based on eating becomes trickier. There's a better case for if their labs are off. So in some ways, oddly, you're kind of hoping that their labs might be off so that you can have a stronger case for them needing to be hospitalized. But if their labs are okay, it's pretty hard to make a claim that they are a danger to themselves, even if you can obviously say that they're. We do deal with that a lot, and I think that's one of the bigger ethical dilemmas about working with eating disorders is everybody has their opinion on like, well, that person has a right to do what they want to do versus like, obviously they can't make a clear decision. So that's one of the tougher dilemmas that we do deal with. So then I'll just talk briefly with families about other options. For college students, they have the option to push for them to take a medical leave of absence. And for older people, and this kind of plays into the comment that you just, or the question you just asked, sometimes we will work with the family to try to gain legal guardianship in extreme cases. If that person's really not making good decisions about their treatment and they're clearly at a place where they are not doing well, if the family can get legal guardianship, then they can enforce that treatment. And then, sometimes for certain families, they really need to add a more spiritual component in, and so we'll want them to supplement with, maybe their pastoral counseling or, something from their faith community that might help sort of make this process feel a little bit more palatable to them. So we'll go into the other remaining weeks. I want to make sure we get through this so that there's time for questions. So the second week is caregiver self-care. And the big theme of this week is that you have to put your oxygen mask on yourself before you put it on the people around you. And so what we really focus on here is I give them a stress level assessment, and we will process it. We'll discuss the sacrifices that they have made for their loved ones and try to highlight the different ways that they might have made sacrifices. The participants, this is a little bit more sharing than the other weeks. The participants can share their frustrations and concerns. We review positive coping strategies and stress management techniques. I usually do a little bit of mindfulness here. And we discuss the importance of creating boundaries and preserving self. And so this particular module tends to be a little bit more sort of individualized based on who's present at that week and what they're willing and wanting to talk about. But this gives them a chance to kind of recognize, like, you know, wow, I really haven't been taking care of myself. And a lot of different people will talk about they've neglected their own medical stuff, so they haven't been going to their own doctor's appointments, or especially in cases where they may have been given specific dietary guidelines for their own health conditions. If they felt like that was going to be too triggering to the person with the eating disorder, sometimes they've abandoned that. And so we need to help them realize it's okay for them to take care of themselves. It's okay for them to, you know, follow their physician's recommendations, and we'll just have to figure out a way to make that okay for the person with the eating disorder as well. And then we review the different supports that are available to the caregivers. So at our center, we have a family support group, which is just a general group for families. There's a large general support group that anyone is welcome to come to, the bibliotherapy, the collaborative care workshops, and, you know, highlighting many people end up seeking their own individual therapy as they're going through this process. You know, for people who have been prone to depression or anxiety, this is going to exacerbate that, and they may have relapse of their own symptoms for things they've battled. And we talk about how family therapy, you know, sometimes they need a little coaching on how to really maximize the family therapy experience if they are participating in that. So we talk about how they can use those things to help support themselves. So week 3, we go over communication and caregiver styles. And the caregiver styles were developed by Janet Treasure. And these are some animals. Now, some of the animals make clear sense to me. Some of the animals I'm not as sure about. But we will, just in terms of like why she picked that animal. So we'll talk about it. Kangaroo, this makes sense. So kangaroos have too much emotion and too much control. So this is a caregiver who has a lot of anxiety about the eating disorder, and their reaction is to be overly supportive to the point where they're really not allowing the other person any space. And so that person experiences that as pretty stifling, and it doesn't give them any opportunity to master the skills that they've learned, which makes them feel worse, and that can make the eating disorder flourish. I had someone I worked with that her mom came to my collaborative care workshops and recognized herself as a kangaroo, and the family affectionately started calling her Kanga. And the girl I was working with was like, please use my mom as an example. And she wanted me to share the example of how she was in college, but her mom would text her every morning, did you take your medicine today? And she found that to be really annoying because she was actually really solidly into her recovery, and she didn't need anybody to be prompting her like that. And she would say, it makes me not want to, or it makes me feel like, why bother? Because she's just going to be doing it anyway. And we've also had other examples of, you know, where families tend to be really monitoring what the person's eating to the point that, again, like I talked about earlier, that person no longer really remembers what they're supposed to be eating on their own, and they have a hard time regulating that on their own. A lot of times we get moms in the kangaroo role. The rhinoceros is an example of an animal. I don't know if a rhinoceros is very logical, but in this example, It's somebody who has a lot of logic but too little emotion. So this person has the anxiety about the eating disorder, but their reaction is to shout and to control and argue, and it makes the person feel rejected. They feel unloved, and there's a loss of trust between the two of them. The person feels worse, and then the eating disorder can flourish in that way. The ostrich is someone who is like, okay, well, they're in treatment now, so it's best to just let the treatment center worry about it. We're not going to worry about it. We're not even going to talk about it. So they may not even allow talk of the eating disorder in the house. As you can imagine, the eating disorder flourishes under those circumstances, and the person feels a lot of shame because, you know, it's something that's kind of meant to then at that point be secret. And then the patient feels worse, and then the eating disorder can flourish in that way. The jellyfish I think of as Chicken Little. For this person, the idea that there's an eating disorder is extremely terrifying. There's a lot of concern. They're worried about worst case scenarios. Everything is dreadful. And then the caregiver starts isolating. It's very tearful all the time. They're losing sleep. And what happens is the person really avoids contact with them, and they feel terrible about how bad they're hurting them. In an extreme example of this, we have had parents who have had to be hospitalized in the context of this whole process because they're like suicidal over the fact that their child is now really sick, and it gets a little chaotic. That's an extreme example. But again, in this example, the person feels much worse, and the eating disorder can flourish. So the ideal animals here are a dolphin and a St. Bernard. And the dolphin, you think of as swimming in a pod. There's a lot of autonomy here. But if one of the dolphins gets off course, you can imagine the other dolphin kind of playfully bobbing them back into, line with the other group. So there is companionship. They're traveling together, but there's a sense of autonomy where the dolphin is helping to guide the person and helping them keep them on course. With the St. Bernard, you think of, nice, warm, fuzzy animal, again, guiding the hiker out of the, mountain wilderness. They're not carrying the hiker, and they're, providing brandy or other types of nourishment along the way. So we have the idea here being somebody that is warm, consistent, a good companion, and is helping guide, but is also respecting autonomy with that recovery process. So I introduce these to the group, and I have people try to pick out which ones they are, and sometimes people recognize a combination of them, and then we talk about what they can be doing to help get them to be more like a dolphin or a St. Bernard. And then we review the basics of communication, and then I let them just roll me over with role plays. So they bring in their worst case scenarios and all their terrible things that have happened, and I will practice and sort of give them strategies for how to communicate with that. And then if there's time, we take turns practicing and talking about different situations that come up and helping them to problem solve through potential things that might come up. During week 4, we go over the trans-theoretical change model and motivational interviewing. So we go through all the different pre-contemplation, contemplation, preparation. I'm sure everybody in here is fairly familiar with these. And we talk about what that looks like for eating disorders, and that it is fluid. And so some people are, maybe maintaining for a long time and then relapse a little bit. And we talk about what is really important as clinicians that we know is that you can't just force somebody to be doing the action steps when they're in pre-contemplation. And so we talk about that, there are different sets of skills that you would be using at each of these levels, and helping the people recognize where their loved one is, and helping to identify what kinds of things they could be doing or saying that would be helpful at that moment. And so because most people who are out in the world aren't really familiar with motivational interviewing. We talk a little bit about, in order for a person to change, that they really must feel like it's important and they must feel capable of making the change, and that we really want them to verbalize how their current behavior is not consistent with their goals. And so we talk about that with the family members in the hopes that they'll, if those types of conversations come up, that they'll help to try to facilitate the conversation in those sort of pathways. There is a readiness ruler that Janet Treasure shared. It's basically a scale from 1 to 10 where, we'll talk about, how motivated are you? Pick a number. So if the person picks a 4, we would say, well, why are you a 4? Why not a 5? Why not a 3? What would it look like to become a 4.5? How do you think we as the family would rate you? Why do you think that? So we give this as an example of how to have a conversation. A lot of the people who I have worked with will use the workshop as a way to start conversations with the loved one afterwards, because they usually know that they're coming and they'll say, this is what we learned in our workshop tonight. So that's a way that they can introduce the topic or introduce, some of the skills that we've learned. But the idea here is really that they are learning basically the gist of what kinds of conversations they want to be having with someone who may not be really committed to making a change yet. Week 5, we go over some DBT kinds of stuff, labeling emotions, talking about appropriate coping strategies for emotions. We do mindfulness skills. We talk about the importance of modeling good emotional regulation, and talking with family members about how to encourage their loved one to share their feelings. And so we'll even talk about, putting on the refrigerator those little faces with the magnet that you can move around, or just starting to kind of use the vocabulary a little bit more at home about different kinds of emotion. And this is, again, if family members will say, like, we have a hard time as a family talking about this, these are the kinds of conversations that can help, the person leading these workshops direct them towards, okay, this would be great to talk about, like, with a family therapist, or giving them some suggestions in the moment that might help them to go through that process more effectively. Week 6, we do CBT. We review the philosophy of CBT. We review cognitive distortions. And I usually hand out a thought log, and we go through one together, as an example. And then we role play how to help challenge some of the thoughts that they see coming up, where at the time they know it's a distortion, but in the past maybe they didn't know quite how to challenge it. We'll talk about ways that they can challenge it in the moment, subtly too, not like they have to be like, time out, let's do a thought log together, but just so that they can give them some good feedback. And then we talk about simple behavior modification, and this is really more for the point where I made earlier about, I used to always recommend, go ask your, go ask somebody for help if you feel like you're going to purge or binge, and this is where they often didn't know what to do if the person came to them. And so this is where we kind of walk them through what behavior mod looks like and what would be appropriate recommendations they could make to the person if they felt like they were going to act on a symptom. And so we walk them through that. So the results of these workshops, caregivers feel more empowered. They have much less anxiety and stress once they've gone through these workshops. And then the loved one has increased support, and some of the early research, this is fairly new, but the early research shows that they may have lower rates of relapse with this additional support. And the caregiver serves as an ally to the treatment team. And it really makes a whole lot of sense, because they're sort of an extension of the treatment team at that point. And so they're really sort of, if it works the way it's supposed to, everybody's on the same page, and there's a huge team of people fighting the eating disorder together, in all the different settings that that person's going through. And so you can imagine how if it's working the way it's supposed to, it really does increase the likelihood that that person's going to be able to recover successfully. So there's probably questions out there. Some of the more common questions that have come up is, what if the caregiver has an eating disorder? And in this situation, we always encourage the caregiver to get therapy. We encourage boundaries and encourage family therapy. But this, I think it's important to note, it doesn't mean that the person's going to be less successful. If the person who has an eating disorder is open to sort of working with the team on, setting boundaries around how much, they're talking with the other person about food, or they're working on their own eating disorder, it can still be successful. It's just that the treatment team needs to be aware and needs to provide extra guidance and support in that. What if the caregiver gets tired of the patient? This happens more often than you would think. We really, really focus on the externalizing piece about the eating disorder really is separate from the person, and try to help them focus on that and hopefully boost their empathy a little bit. And if their loved one just won't go to treatment, we try to offer as much support around that, but again, we need them to recognize that unfortunately, especially for adults, the person does have the right to refuse treatment. And that's hard for all of us to kind of acknowledge, but we want to leave the door open, continue to have conversations with them, emphasizing the support available to them, but unless it's extreme and they can get the legal guardianship, there may be a limit on what they're actually able to do.